tibialis posterior, flexor hallucis longus, flexor digitorum longus. It enters the flexor retinaculum along with the tendons. Did I give you a mnemonic to remember the relationships here? No, that's up at the top. Oh no, this is much. Let's see. Oh no. That happens to me. I know when we did the muscle, I would have given you Tom, Dick and Harry.
Yeah.
Tom, Dick and Harry obviously are players here, but we're going to give you something totally different. This reflects the current state of East Midlands football quite nicely. Oh no, Midlands football. Derby's East Midlands. Aston Villa. There's West Midlands. I'm not giving you that. Today, Derby versus Aston Villa, no problem. Tibialis posterior is working from medial to lateral and from front to back. Tibialis posterior today, Derby, flexor digitorum longus, vein, artery vein, so we've got these two phenatomic antae either side of the posterior tibial artery. Next comes the tibial nerve, and last of all comes the tendon of flexor hallucis longus. If you're thinking to yourself, ladies, I couldn't give a toss, football is of no interest to me whatsoever, there is an alternative version which is inherently effective, but I can't help that. Timothy does flex all day with his house parents. Okay. It's important that you know those relationships because next semester you're going to be stabbing people with needles. And what we don't want to do is injecting foreign proteins into arteries or veins. We don't particularly want you pushing your needle through tendons either. It's exquisitely painful. If you actually push your needle through the nerve, that gives you some really quite weird sensations. Not particularly painful, I have to say. But you can feel nauseous. And you can sort of feel an uncomfortable, unpleasant sort of tingling as the fibres of the nerve part to allow passage of the needle through it. It's strange because it doesn't actually hurt. Actually stab the nerve itself, it doesn't actually hurt. It's not comfortable. Okay, so that then is tibial nerve down to the ankle. The tibial nerve then passes around the ankle. Today, Derby versus Aston Villa, no hope. Timothy doth vex all very nervous housewives. The veins aren't shown on here. There is the tibial nerve entering the flexor retinaculum. In the middle of the flexor retinaculum, to cover the flexor retinaculum, it bifurcates into its two terminal branches. So one nerve enters the flexor retinaculum to emerge. And this is the point where nerve entrapment occurs and is known as, the symptoms are known as tarsal tunnel syndrome. So tarsal tunnel syndrome is a consequence of nerve entrapment of the tibial nerve in that flexor retinaculum. A nice classic test for that is called Tinel's test. And basically what you should do, if I can borrow a foot, you don't need to keep shoes on. Just lift up one leg. You do. What you do is just tap, sharply tap, just behind the medial malleus. This sort of lower 1/8 of the leg, somewhere around about there. Just sharply tap there, and that will set an immediate tingling if the nerve is entrapped. That's called Tinel's test. Tinel apostrophe S. Tinel's. Or Tinel's sign. So, tarsal tunnel syndrome then is due to entrapment of the tibial nerve in that flexor retinaculum. The medial plantar nerve is the larger of the two branches of the tibial nerve. It supplies the skin of the toes of the medial 3½ toes. So it supplies the medial 3½ toes. The lateral plantar nerve supplies the remaining 1½ toes. So if we were to ask you then, which nerves supply the 4th toe, if you want to do a digital nerve block to operate on that 4th toe, which nerves would you have to zap?
Medial and lateral.
Yes, any others?
On the top, yeah.
Superficial perineal nerve on the top. The medial plantar nerve supplies 4 muscles. And if you remember those 4 muscles, you don't actually have to remember what the lateral plantar nerve supplies at all. The medial plantar nerve supplies abductor hallucis in the first layer, flexor digitorum brevis in the first layer, flexor hallucis brevis in the 3rd layer, and this one out in the 2nd layer, the first lumbrical muscle. So I'll just do those again. 4 muscles supplied by the medial branch of the medial plantar nerve, abductor hallucis, flexor digitorum brevis, the first lumbrical muscle, flexor hallucis brevis.
Any reason you wouldn't take the easy route and do your blocks up here?
Nerve block.
Yeah.
You can blockade the ankle joint completely if you wanted to. Depends where you plan to be messing about with it. Plantar, a posterior ankle block, a posterior tibial ankle block, you blockade the ankle if you want to inject that. And that will knock out everything done by these plantar nerves, all. So it's the one that we're more likely to perform is the nerve blockade of the tibial nerve. But you can not blockade the deep perineal nerve if you're working on the top here somewhere. It's easy, probably, just to infiltrate around the nerve fibers at the base of the toe.
Can you damage nerves injecting into them?
Can you do what?
Can you damage a nerve by doing
It takes some damaging, to be honest. They're fairly robust, in spite of the fact that some of these are fairly small, fairly robust. When you get down to this level, it's unlikely that you're going to actually pierce the nerve. Particularly with modern silicone needles, they could hit the nerve and the nerve will just roll to one side. It will just skip to one side as the needle passes through. Same with most of the blood vessels, they'll just move to one side with this fine silicone needle. Some of these larger vessels and the larger nerves, yes, you will actually perforate them if you don't know what you're doing, and pass straight through them very often. So it doesn't mean to say that necessarily you're going to inject anything into the artery, because you keep on going and you will come out the other side too. But it's not a clever thing to do nonetheless. It will cause hemorrhage and massive bruising and a very unhappy patient. Worst case scenario is that you actually inject into the arteries and you're putting, as I say, this synthetic protein into the blood vascular system. Not a clever thing to do. In the days before self-acerating syringes and sealed cartridges, the other great thing was that you'd actually put air into the artery, and an air embolus would have serious complications. For example, a cardiovascular incident, cerebrovascular incident, you'd induce a sort of stroke basically with an air embolus in the brain. Killed nice and easily. And the other place that this air embolus could lodge is in the coronary arteries. Same outcome. So an air embolus is not a clever thing to have. Which is why you see on all these hospital dramas, although it's no longer necessary, squirting first to expel all the air from the syringe before they inject. But the multi-dose ampules now are very, very much no-no. A little glass bottle with a rubber diaphragm that you actually fill up from. Now obviously you do draw air into the syringe without needing to express the air from the syringe before injecting. But multi-dose ampules like that are obviously a source of infection, so they're not used any longer. Pretty well every drug, injectable drug, comes in a sterile, self-contained cartridge these days. So aspiration is not actually necessary 9 times out of 10 these days. And the other innovation in syringe design is the self-aspirating syringe too. So the syringe will aspirate automatically as soon as you stop pressing on the plunger. It will just automatically aspirate. The thing about aspirating when we're injecting is it's a good way of making sure you're not in the cartridge. Because if you aspirate, you will draw blood up into the cartridge. You know you're in. You aspirate before you inject. If you draw drug up, you come out quick and start all over again. And try not to have to confess to the patient that you popped up. You might just say, I'm just going to top that up now. Just leave it for a minute and we'll just change the syringe and we'll top it up in a moment. Right. So that's that. That's the sciatic nerve from top to bottom.
You happy with that? Good. Anything else? I intend to leave you. I've got a naughty girl coming to see me at 11:45.
Ooh.
I hate this part of the job. I just feel so stupid.
I'll do it, sure.
No. It's very bad. I'm not a school teacher. I don't. People have it. They know what they're doing. If they don't bother to come, fine. I don't give a shit whether they come or not.
What's she done?
Well, no, absolutely fuck all when it comes to the exam, wasn't it? They will pan out one way or another. Without having to slap anybody's wrist. Sorry, he was saying something.
What's she done?
What she's not done.
No.
Not been.
Do we know her?
Oh, no, I don't even recognise her. I'll have to look at the photograph. I've had a mild wrist slapping from Peter Bowden and then from Alison Barlow for not actually having invited this lady to see me earlier. It's week 10. How long is it since you've seen her? That would be 3, 4. Right. So that's that. Anything else you want briefly to do in the next 10 minutes?
Arteries.
Arteries. In 10 minutes.